Kieran Anderson here, group publisher at Applied Radiology, and I am here live at RSNA in our booth, and I'm so pleased to be joined by Dr. Davide Ippolito, who is a board-certified diagnostic radiologist working in Monza, Italy at the San Gennaro Hospital Center, and also a professor of radiology at the University of Milan. Is that correct?
Exactly, yeah, it's correct.
Thank you so much for joining us today.
It's a pleasure, and thank you for the invitation.
Absolutely. And I'm also joined here by Dr. Nils Hokamp, who is a senior consultant in radiology, oncology imaging, also working in Cologne, Germany at the University Hospital of Cologne.
Thanks,
Dr.
Kieran.
Hokamp, thank you
Great
for
to be
joining
here.
us. It's
Thanks
great
so
to
much.
be here. We're here at RSNA and so much going on, and thrilled to have you both in our booth here. We're going to talk a little bit about some new CT technology, some new scanners you both have in your institutions. You have different scanners as I understand it. I'd love to start a little bit first with you, Dr. Ippolito. Tell us a little bit about your facility, your patient mix, what that looks like, the kind of volumes you're typically seeing today.
Okay, yeah, I work in a tertiary referral center in north of Italy, in quite close to Milan, so it's a quite huge hospital. And usually we do about 200,000 examination, including MR, CT, X-ray, and so on. And we are quite lucky because we have 4 different CT scanner, 4 MRI scanner, one of them is 3 Tesla, and we have several ultrasound equipment and X-ray as well. And so we have a great, huge team, and usually since our center is also a trauma center, we have a high amount of emergency cases, but also outside and different kind of patient and oncologic as well.
Very interesting. Thank you for sharing that. And Dr. Hokamp, would you also tell us a little bit about your facility and sort of patient mix and how things are going at your university hospital?
Sure, perfect. So the University Hospital of Cologne is one of the largest medical centers within Germany. We have roughly 1,600 patient beds. The health network sees 500,000 patients a year, including in and out patients. And so, I mean, this basically transfers to the radiological department, right? Similarly, we see roughly 200 to 220,000 exams a year, including all types of imaging studies. When it comes to cross-sectional imaging and computer tomography, it's roughly 125 cases a day in routine business days, and another 50 or 60 on the weekends and so on. So it's a quite big caseload that we have over there.
Yeah, that sounds like a busy center for sure. And Dr. Ippolito, if you would take a moment to maybe talk a little bit about the types of cases you're performing on a day-to-day basis. Is it primarily cardiovascular imaging? Are you also doing other studies? If so, please share.
Yeah, well, our hospital, I would say that he has 3 different missions. The first one is an oncological hospital, so we do a lot and we follow a lot of patients with several different oncological disease. But we have also one of the biggest trauma centers north of Italy, and we work also with Formula 1, and we had a lot of experience also with drivers. And finally, we have also a pediatric area. So I would say that we have to cover this different area. And cardiac imaging is part of pediatric and adult imaging to cover the needs of those patients, not only from oncological point of view, but also from cardiovascular point of view. So we have a lot of facilities, and we cover a lot of different topics in radiological domain.
Interesting. Thank you for sharing that. And back to you, Dr. Hokamp. How about yourself? What kind of a caseload are you seeing? What type of cases are you doing primarily?
I mean, myself, I'm focused on body and oncologic imaging, so these are the cases that I typically read. As said, I mean, being a large, also teaching hospital, we see all types of cases, including neurology, including body imaging, including MSK and all that. So it's a wide mixture. If you would put a focus on emphasis, what type of patients we see the most in Cologne, it will be oncology, because we have one of the biggest oncology clinics, actually I believe within Europe. So
right?
yeah, so these cases make up a lot of the patients that we see and that I read every day.
And then I imagine that, has an effect on like what kind of equipment you want, right? And what kind of equipment you're using. And as I understand it, you've been using the Philips 7500 spectral CT scanner. Is that correct? Tell us a little bit about how that's operating for you and what's that like working with Philips?
Sure, in order to get a good understanding and how we developed and implemented Spectral into a reading workflow, it's important to understand that we didn't start off with the 7500, which was installed 2 years ago, but the Spectral era goes back to 2016 when we started with the first Spectral CT system, the Icon scanner. Since then we have collected a lot of experience. The Icon scanner stands in our routine operating headquarters, so to speak, and the 7500 is now placed in the emergency department where we see patients 24/7, and it is a quite big caseload of studies that we see there, and also a wide variety because, as you mentioned that as well, in emergency setting you don't really have an option and to true decision which cases you want to see and look at.
That's right, that's right. And staying with you here for a moment on that, Dr. Hokamp, let's talk about the technology and specifically the always on, right? Spectral is always on, and from what I understand, there is some benefit to that, but what kind of difference has that made in your practice from both a clinical and maybe even an economic perspective? Does it help with patient management?
To understand this and the benefit of this always-on concept, it's important to go even back more in time. Back in 2008, when dual energy CT was introduced, it was a prospective protocol imaging decision. So basically you had to know, do I want to use dual energies or spectral, or don't I? You have to decide that before you schedule a patient, and particularly before you decided on a scanning protocol. And this changed when spectral detector became available, due to the plain fact that the dual energy data is collected at all times. I mean, there's technically no way to turn it off. And while it can be integrated into a full conventional image data set, you also have the opportunity to get the spectral results for free, basically. And the price that you have to pay for that is just a couple of minutes of reconstruction time. That's quite affordable. Think about the economic perspective and the economic impact. This will depend on the local health system and health remuneration setting and so on. For us, it's important that there's quite a fair share where we can avoid additional exams. For example, when you talk about adrenal adenoma imaging or so, you have an adrenal mass which you are uncertain of its origin, and with the spectral results you can have a good chance of stating that this is just a plain benign adenoma, so it's nothing that you need to worry about, that you should consider to further workflow, that you don't need to do an additional MRI examination afterwards. This is the economic perspective, but this is also important for the patient because he has certainty in the first approach and doesn't really need to worry for another week or two while he waits for this other exam.
Yeah, no, that absolutely makes an awful lot of sense. And I think, you in a way answered my next question about it, because just having the spectral results in every scan really does provide that benefit from a clinical standpoint. Like you're able to see things that you might not have seen before. You don't have to do that extra imaging potentially.
Yeah. So, right, I mean, the characterization part is one thing, and then the other part is that you just get the better images in first instance. I mean, you are familiar with the system as well. If you look at virtual monoimagetic images, those are to me, they are the better conventional image. So that's the image that I read in first place, and I don't really worry about the conventional image anymore. So it is in both settings. So routine, daily workflow, and then also characterization of findings that you want to characterize any further.
Right. And just sort of to wrap it up a little bit there on that, what, in your opinion, excites you the most about this 7500 spectral CT scanner? Like, for example, I understand you do a fair amount of quantitative imaging as well, right, with biomarkers. Has this scanner made any difference in that area?
So research-wise, I've been focusing on iodine as a quantitative biomarker in oncologic imaging for the past 8 years, basically now. And the always-on approach allows us to collect these type of data for all cases that we examined ever since. And this is very helpful because in order to get meaningful research and to generate a clinical impact out of such studies, it is important to have a reasonable caseload, and this can only be achieved by such a big archive we're looking at more than 100,000 spectral CT examinations by now. So that clearly helps there. That's a benefit.
And Dr. Ippolito, I understand you too have recently replaced a scanner. You had an ICT, is that correct?
Exactly, yeah.
And you're now using the new 5300?
Yeah. In the last December, we replaced the oldest CT scanner, the ICT, that had an 8 centimeter panel, and we moved to this new technology. So the new precise scanner 5300 that has a smaller panel, but it is equipped with a AI-based algorithm that help us in management of patient from several point of view.
Right.
Starting from patient scanning, reconstruction of images, and post-processing. So the AI workflow include all of the management of patient. And since today the AI is one of the most important topic in everyday radiological life, we decide to move on, make a step forward, and understand the value and the strength of deep learning in everyday clinical practice. So this was the most important reason for us.
That makes an awful lot of sense. How did you kind of make that decision to move from the ICT to the 5300? Was it features like the AI, for example, or was it have anything to do with some of the other things like the radiation dose strategies that are available on it, maybe even some of the economic impacts, that are available as well?
There were several reasons why we moved on to this new kind of technology. First, we know that this new CT scanner is equipped with a tube that is guaranteed for the entire life. So first, it means that we can save money. And since we can work with artificial intelligence, we can also save money in different way, because we now are able to work with the really low kV settings. That means that first we reduce the radiation dose for patients. Secondly, we reduce the intensive energy consumption. So combining the reduction of radiation dose, the reduction of exposure, and saving the tube, it's a great advantage. And we should not forget that when we reduce the kV setting, we increase the contrast detectability of the object, so everything becomes wider. And we can save more money because we can reduce also the contrast agent. So it was a great step forward for in the future, and to work in line with the environment and with sustainability,
right,
for sure.
It certainly makes sense. Now, did you feel like you sacrificed anything, right? Image quality is key to everything, right? At the end of the day, it does come down to the quality of the images, and certainly that's top of mind for all clinicians, right? Getting it right the first time is always the goal. So in your experience, like, what would you say, about the images, particularly your cardiac cases, right? Because can you really get good cardiac images on a 4-centimeter system?
When we installed the system, we were a little bit afraid to be not able to perform good cardiac imaging with a 4-centimeter panel. But we understand the strength of the AI system that is able to obtain a very high diagnostic quality of images. Because in our history, we work at the beginning with the hybrid approach, then we move to the model-based, now to the precise. So every 4 or 5 years, we make a step over and exploring more the physics of the images. And the precise cardiac has this possibility to make a high diagnostic quality.
Right.
And fortunately, this new CT scanner has a good rotation time that is 0.35 seconds. So it's really good. The spatial resolution is 0.6 millimeters. Okay. So the combination of quality, spatial resolution, and fasting of rotation times allow us also to perform cardiac imaging. So everything was perfect, I would say.
That's great. That's great. Now, I know you said you've got a couple of different scanners in your institution. Any thoughts there on that same question to you?
I mean, as David mentioned, when you think of cardiac imaging, if you have the opportunity to utilize an 8-centimeter detector, in particular, if you get the spectral results in addition to the standard anatomical imaging, it's a quite easy choice. Only thing that limits our freedom of choice there is, again, the setting in the emergency department, because if the scanner is busy, we can't really do our cardio scans there, which just take a couple of minutes longer compared to a standard CT scan. In these cases, we switch to one of the other systems. The Icon with the 4-centimeter detector provides good images as well. So it's not a true choice, but having the opportunity of going for 8 centimeters and spectral, it's a great opportunity.
Win-win, a win-win. How about some of the other features on these scanners, like the reconstruction software? I don't know if you're using Precise Image or not, which I believe is also part of that CT Smart Workflow kind of suite of tools on the scanner. How is that working for you? And have you really been able to go pretty low?
Yeah, the CT Smart Workflow is a unique heading characteristics of this new CT scanner, because it works in several moments of CT imaging and CT acquisition process, because we start from patient scanning, reconstruction of the images, and post-processing. So the application of CT Smart Workflow, that is AI-based again, may increase the efficiency of our CT scanner, because the protocol is more reproducible.
Right.
Because the AI help us in make the correct center of patient, make it in the ISO center, because we have a camera set that is able to recognize the anatomical landmarks. That means that the results during the follow-up of the patient will be the same for all of the time. And so we can save time during the preparation of patient, and we can help the work not only for radiologists, but also for radiographers that are really enthusiastic to work with the AI based, because the radiographer can stay inside the CT scanner room, or we can do it also outside, because the camera helps us and the AI is able to make the patient in the correct position. So we have several advantages to work with this new system. And obviously the precise image is able to increase dramatically the quality of the images.
Right. And does this play into like radiation dose savings as well? Like, I mean, can you expand on how effective the system is at really maintaining low radiation doses without sort of compromising image quality?
To be honest, I think that nobody really knows how the black box of AI works, but we know that the system was trained with really full dose images of very high diagnostic quality. Then the system was trained with poor quality of images, and the system were able to restore the same kind of high diagnostic quality. On this basis, we decided also to shift our protocol. For example, in body imaging, we moved from 120 kV setting to 100 kV setting. While in cardiovascular domain, so including angio of the aorta, of pulmonary embolism, and cardiac as well, we moved from 100 kV to 80 kV, and the final result is the same of a highest dose. So it means that in this way we were able to save the dose ranging from 33 to 80%, according to different domains. That's a great gain from a clinical point of view and for patient safety as well.
That's really great. And you mentioned artificial intelligence a couple of times, and I'm just curious, how have you really incorporated that into your workflows, but also into sort of the into your clinical use of this new system? Can you share any examples of how that's happening? Maybe how the CT Smart workflow has optimized your daily operations?
Okay, it works in several moments of CT analysis. First, regarding the patient positioning inside the room, because the camera recognizes the patient, recognize the name, the anatomical landmarks, and put the patient in the isocenter.
So that would reduce errors, right?
Yes, exactly. Should reduce the amount of error. It was calculated that it was about 70%. And we can reduce also the preparation timing. Then the protocol is automatically selected by the scanner, because he recognizes the patient name, he knows which area we should study, and so he automatically recognizes which kind of protocol we should use. And then the precise image is important to obtain the best quality of images after acquiring the patient. So the precise image is part of the cardiac analysis. And what is really important now, we have another great algorithm that is called the precise cardiac, which aim is to realign the coronary artery vessel in those cases in which we have artifacts. And I think that also Nils have this great opportunity that works with all of the CT scanner from Philips.
That's really, really great. Would you say that that's one of the most unique features on the 5300 CT scanner, or is there something else that would be one of the most unique features?
I would say that the great features are not one. It's the possibility to work in a different domain. You can use the precise in the brain, you can work in pulmonary embolism, cardiac CT, without any compromise, abdominal imaging, staging of patient, and especially in the emergency department, because the precise image offer the images in real time. So we acquired and we see immediately the results. It means that when we work with trauma patient, we have to not wait, like with the previous reconstruction algorithm. We are already ready to give the information to the surgeon, to the orthopedics and so on, in a very extremely condition.
Excellent, excellent. You know, and Dr. Hokamp, same question really as it relates to the 7500 in terms of some of the, unique features. What have you found to be the most unique advantages of the scanner itself?
I mean, I won't just talk about spectral anymore, because back in 2016 we made this choice that we will stick to spectral, and having had this learning curve, there's a study that we don't really want to miss. So spectral is a great thing to have, and it's actually, for me, it's the only way that CT should be like.
Right.
Talking about the 7500 system, what is great, in particular in the emergency setting, is that we have a patient couch that is like longer than 2 meters, and this includes the entire scan range. So basically, we drive in there with our patient bed, we carry this patient on the CT table, but it doesn't matter where we put him precisely because we have such a wide field of view in the Z direction that we can truly use that and that we get the good images in very limited time. So that's a great thing in the emergency setting.
For sure. How would you summarize how the 5300 CT scanner from Philips is meeting your needs, not only from a clinical perspective, but also an operational point of view, and even an economic? I mean, you've alluded to it, so maybe just a sort of a summary statement about it all.
Well, let me say that the 5300 is not a scanner like the Spectral, that is the top from Philips, or like a photon counting. But even if we work with this scanner, we can cover all of the anatomical and clinical domain. So we are able to answer to the different clinician question, and we can work saving cost first, having a tube that is guaranteed for the entire life. Again, we save cost, we save contrast agents consuming, and again, it means saving cost. So I would say that with this scanner, we are able to answer to all the need of the hospital. And we know that the environment now is a great point, is a not hot topic. So we should say, if we can work in this way, in line with the environment, this scanner is moving the correct way. So the physician is happy, the radiographer is happy, and the radiologist as well with the results of AI-based algorithm. So
that's great. Thank you for sort of summarizing that. And you know, Dr. Hokamp, what would you say as well? Would you think about the 7500? You know, just sort of a summary statement. You know, how you feel about the scanner as a whole?
I mean, the scanner is the next generation spectral CT system, right? We have an 8 centimeter detector, which allows us to image anything that we possibly want. We get great cardiac studies. We have very, very high acquisition speeds in whole body, in trauma imaging and whatsoever. And we get the spectral results, and they basically come for free and are very useful in a variety of cases.
So I'm guessing you both would agree that these sort of next generation scanners are delivering really deeper clinical kind of insights and helping to answer much more, you know, more complex questions and cases.
Yeah. Because we can look deeper inside the images from different point of view, and the clinician deserve this information in the emergency, for oncology and different fields, and the new CT scanner, the new panel detector offers a lot of advantages.
Right.
And it's not only the physician, it's also the patient.
Yeah.
But yeah, it's a great system.
Right. Yeah. And you know, just a sort of final question, in terms of like ramp up and getting, you know, not only your physicians trained, but your radiographers, or as we call them, technologists here in the States. What was that like? I mean, was it a quick learning curve?
Yes, we were quite lucky in our history, because in the past we had the hybrid iterative algorithm, we moved to the model-based and now to the artificial intelligence. And at the beginning, we need, I think, 1 month or 2 months to become confident with the new results. While with the AI, let me say, the second days of working, we set the protocol and everybody was happy.
Set it and
the
forget
physician,
it.
The clinician, the radiologist, and radiographer as well. So it was really strange, as immediately the results, you can get immediately the efficiency and the importance of AI every day. So it was really fast and really simple.
Well, that's great. Well, listen, I just want to thank you both for taking the time to visit me here at my booth here at Applied Radiology, here at RSNA, and really sharing your clinical experience, but also your, you know, what you're seeing in your institution as well from a workflow and efficiency perspective with these new CT scanners from Philips. I want to thank you both for taking the time.
Thank you.
Dr. Hokamp, Dr. Ippolito, thank you.
Thank you so much. Has been fun.
Appreciate you both.